So when I got to Palm Beach County Fire Rescue, which was January 1st, 2015, we were pretty much following the standard ACLS protocols that everybody else was following along the state. And we looked at that and we decided, you know, we're not really doing as well as we think we could do here for our sudden cardiac arrest victims. So one of the things we started looking at is how well are we doing already? And we saw we were at about 16% return on spontaneous circulation rates for our county, and the state of Florida was roughly at about the same area. And this is all based on 2010 AHA guidelines. So we started looking around the country. We realized that, you know, there are some communities that do really, really well with sudden cardiac arrest. What are they doing differently? And we looked at places like Seattle and Arizona and some other areas. And so we took some of those best practices and we started putting them into place in Palm Beach County. And what we realized is that there's been a lot of focus in all of the ACLS classes that really on things that don't make the most difference. One of the big examples is the medications. Well, you realize that really none of the medications make any difference in adult cardiac arrest survival, yet a lot of the focus on the courses are on that, so that's where our paramedics seem to focus their efforts on. But when you actually take a look at it, it's really all about how you manage the airway and how you handle chest compressions. So we know that from prior studies, there's a peak rate, a peak percentage of time, and a peak depth that you push on the chest that gives you the highest survival rate. So we really concentrated on the mechanics of how you do CPR. And we took the airway issue and we realized that, you know, in people with primary cardiac arrest, meaning they collapsed because of their heart, not because they went into hypoxia, the folks, and that's about 90% of the folks in primary cardiac arrest as adults, those people have about a 10-minute oxygen supply. So really, we don't need to do the airway, the positive pressure airway management right off the bat. So what we did, the two first things we did was we really maximized continuous nonstop chest compressions at the appropriate rate and depth with minimal interruptions. We really hammered home, do not stop chest compressions at all for really any reason, unless of course the patient pushes you away. And then for airway management, we really said, you know what, let's delay the airway management for the first 6 minutes because we know we have enough oxygen for about 10 minutes. So we don't do any positive pressure ventilation for the first 6 minutes. And the reason for that is because positive pressure ventilation decreases blood flow during chest compressions. And what we saw was a dramatic rise. Just those two things, we saw a dramatic rise, but we added a few other things. Some of the things that was actually introduced to me by Dr. Paul Pepe. Now, Dr. Pepe is actually the person who came up with the chain of survival. So what we did is we actually looked at all the links in the chain of survival. You know, early 911, early defibrillation, early EMS, all the way out to post-resuscitative care. And we decided, and we actively worked on every single link in the chain. And so we started working on dispatcher life support. So with dispatcher life support, our ROSC rates went up even higher. We noticed that we had a big jump in our bystander CPR rate. We had been hovering about a 20% bystander CPR rate before our dispatcher life support program. And then we modeled it after the King County and Anchorage and Los Angeles no-go model for their dispatcher life support, which is a series of few questions that you quickly, helps our dispatchers quickly identify cardiac arrest and get the caller to start getting hands on the chest right away. And we do hands-only CPR. We do basically chest compression only CPR before fire rescue arrives. And we found that the bystanders really are more willing to do that because none of them really want to do mouth-to-mouth. That's been one of the traditional issues. The other thing that Dr. Pepe brought to us was something called head-up CPR. And that's actually something we're working on. That's not really a mainstream thing yet, but it is something we started experimenting on in Palm Beach County. And we're going to be doing some more experiments on that in the next year. But the theory is this, is that when you're lying flat, your head is full of venous blood. And if your head's already full of venous blood, how are you going to get arterial blood in there during CPR? So if you imagine you're on a monkey bars, you know, you're a kid, and you're hanging upside down, you feel that venous blood rush. That's what we're talking about. The head is full of this venous blood. So we want to tilt the head up during CPR so that the gravity will allow the venous blood to leak out. And in a swine model at least, something that Dr. Lurie and Dr. Pepe have been working on, in a swine model, we see that you drastically improve the cerebral blood flow. And in that same model, they had better neurological intact survival. So we actually did a feasibility study on that in Palm Beach County to see, can we pull this off with our current equipment? And we came up with a way to do it. And so we put that in the mix of our ingredients. And the last thing we're working on is resuscitation centers. Based on the Arizona model, Arizona found that just getting the hospitals to do some of the standard stuff in protocolized measures like targeted temperature management, early cath lab, they've doubled their survival rates in the state of Arizona using resuscitation centers. So again, it's another link in the chain that's sort of, we haven't really focused on because we weren't getting pulses back to begin with, so it was sort of an afterthought for most folks. So to go back to where we started from, we were at 16% back in 2014. That was our ROSC rate, and that was the state average. And then literally within a matter of a few months of putting in some of these changes, we rose up to the 35 to 40% range. And then just recently, our most recent month, September 2016, this is really 1 month after we started our dispatcher life support with the no-go program, we saw that our bystander CPR rate jumped from 20% to 35% bystander CPR rate, and our ROSC rate rose from 40% to 53.5% ROSC rate. So we're having really some tremendous success, but there's really nothing unique to this. Other communities have pulled this off as well. The formula is there. We just really need people to start adopting some of these. And so putting all these various new methodologies in place was really done sort of as a collage. So you could do things stepwise and incrementally, or you can just simply rip off the Band-Aid and do it all at once. And we chose the rip off the Band-Aid method because it was our feeling that there are better ways to do this, and the longer we delay putting out these best practices, the more lives we could have saved. So what we decided to do is basically retrain all of our folks in how to do continuous chest compression, delay. We make sure we minimize the interruptions in chest compression to no more than 5 to 10 seconds at a time. In fact, the way we do our defibrillation is we use the Lucas devices, but you can do this with manual CPR too. But what you do is you do continuous chest compressions, and then you stop for a maximum of 5 seconds just to look at the rhythm. And if you find out that it's actually a shockable rhythm, you immediately go back to chest compressions, and then we charge the monitor. In our case, it's while the Lucas device is going, but if with manual CPR that works as well too. You have the manual CPR going continuously, and then when you're ready to shock, if the Lucas device is going, you just shock the Lucas device. It doesn't care. Or if you have manual CPR, you just have them hover over the chest, give the shock, and immediately go back to it. So we put that method of CPR, the airway management, the head-up CPR, we put all of that right up front, and that gave us our initial jump from 16 to 35, 40%. And then later on, because it was a different crew, we did our dispatcher life support stuff, and that gave us our next jump from 40 to 53.5%, which because it increased the bystander CPR rate for us. So it was incremental only because it was two different groups, but we did multiple things for one group, and then we did the dispatcher CPR for the next group. So we've had some significant success, but I think there's more areas for improvement. When we talk about bystander CPR rates, that's a critical link in the chain of survival. Our own local data shows that the folks that walk out of the hospital neurologically intact, and by the way, that's its own success story. I've had folks that have been working with us for decades, and they've had maybe 1 or maybe 0 neurologically intact cardiac arrest survivors, and now it's literally a monthly thing where we have these folks coming out of the hospital going to thank the crews. So it really kind of reinforces the behavior that they're doing. We're deviating from standard ways of doing things, but now they see the human portion of this when they have the family members and the victim themselves showing up thanking them. But there's a lot more we can do. When it comes to the bystander CPR piece, the folks that walk out of the hospital, 100% of them received bystander CPR. So that link in the chain is critical. We've been able to raise our bystander CPR rate with our dispatcher life support instructions, but there's other ways to do it. We have a countywide hands-only CPR instruction program in all of our schools. So it's a free program. We do it every year where we teach a group of what we call our medical magnet program kids to be hands-only CPR instructors, and then they go out and they teach all the 9th graders in all the high schools throughout the county. So over years, we're training literally thousands of lay rescuers. So that's one program. And then there's these social media apps, something like PulsePoint, for example, which we're putting into place in Palm Beach County over the coming months. The way PulsePoint works is folks who know how to do CPR and are willing to act, they'll be notified when dispatch is notified that there's somebody in a public area nearby them who needs bystander CPR. So we'll have that again to boost the bystander CPR rate, because that's a critical component to the success. So that's one area we need to work on. The resuscitation centers is something we're working on. That's that last link in the chain, and we're planning to put that in place by summer 2017. Now, to be fair, a lot of our hospitals already jumped on board. They've seen all the cardiac arrest saves that we've had in the field, and they're really getting on board with the Arizona model with the cardiac arrest receiving centers that they have in Arizona. In Arizona, they doubled their neurological intact survival rate, but basically just by doing that last link in the chain, which is targeted temperature management, early cath lab, et cetera. So we have those protocols going on across our STEMI receiving hospitals in Palm Beach County right now, who are all eligible to be resuscitation center receiving hospitals. So we're working with our hospitals right now sort of to set up all of the protocols and the algorithms, and we will be preferentially taking our cardiac arrest victims to those centers once they're certified. A lot of the things we're doing are clearly proven best practices in other communities. One thing is obviously unique is the head-up CPR, which I think there's something to that. But I think it's important to realize that this is not a proven concept in humans yet. So this is really research stage stuff. However, when you look at enacting things, there's really no science that says flat is better than up. So I think from a moral standpoint, there's nothing that says that one is better than the other right now. So I think it's certainly an area that's ripe for study. And at least in fact, you can say there's more evidence that head up is better because at least there's a swine model that shows that head up is actually better than leaving them flat. So yes, when we bring our folks in with the tilted up stretcher and they see that the Lucas device is going, it kind of looks a little odd. So the hospitals have asked us about this, and we've sort of let them know about it. And of course, we let them know it's research, but they start adopting it. I actually start seeing them doing it in the emergency departments now. They lift the head of their stretcher up because they're believers in it. We have so many survivors now that they realize that we're doing something right. Now, we've put a lot of ingredients into this mix, and we don't know the individual incremental benefit of each one of these things, and that'll come later, as we start doing more randomized controlled studies to see what's the benefit of each particular part of this. But clearly, this whole collage of all the ingredients all at once has gotten us from 16 to 53.5%. And this is clearly a reproducible thing. We've done it with other agencies other than Palm Beach County as well. So this is something I'm hoping that the people watching this will bring this to their own communities, because it's not rocket science. It's simple things. So just some of the take-home messages are this. I think traditionally we've looked at cardiac arrest in the wrong manner. We focused on the wrong areas. We've really concentrated on airway breathing when really it's circulation that is the thing. We've concentrated on medications when really it's the performance of the chest compressions, minimizing delay, minimizing the interruptions to chest compression is really where it's at, and not hyperventilating patients. So one of the ways I teach my paramedics is kind of using an engine model. So if you've got an adult person, that's like an old engine with 100,000 miles on it. In primary cardiac arrest, what's happened here is the engine's shut down. You got a full gas tank. So the gas tank is the oxygen level. So adding more gas to the gas tank doesn't help you. So focusing really on being the engine, which is continuous chest compressions, and at the same time minimizing the gas. There's no point, and one of the things we all see this, and we're all guilty of this, when you start doing bag valve mask, you're only supposed to be doing one breath every 6 seconds or one breath every 10 seconds. Everybody knows that number, but when you watch them, they're doing it really fast. So I warn them to actually use mental cues. I tell them to count Mississippi's in their head. And when they're pushing on the chest, they know they're supposed to be doing 100 to 120, but again, they need mental cues. So I tell them to sing row, row, row your boat, row, row, row your boat. That actually puts them right at those two things. Those are things that we teach lay people, and it actually works, and that's actually been part of the success. Simple cues like that.